Right. Thank you so much for coming. So welcome everybody. It's 12:30. We'll make a start. So this is the North Central London Cancer Alliance's working in partnership with across both our NEL, NCL regions, our haematology update. This is the second of our haematology talks, and this one, Sajir Mudai is doing it for us. And Sajir, I'm going to let him introduce himself a little in a little while, but he's coming to give us a general update about general haematology referrals and when should GPs refer. There's quite a lot of echo noise, so if you're not speaking and you're not a presenter, perhaps you could put yourself on mute. And if you turn off the cameras, then apart from the speakers, it may be helpful with our bandwidth. In terms of questions and queries, please post them in the chat and I'll draw you in when appropriate. And so you can see the questions as well. So we'll take those as we go through the event. And have a lovely afternoon. So thanks very much, Sajir. You're at UCLH and North Mid, but more than that, perhaps you'd explain a little bit to us about your background. Thanks so much.
Thank you, and thanks for the introduction. Just so that everyone knows who I am, you may have referred patients to me or seen letters from me. I work joint site across North Mid and UCLH. My main interest is lymphoma, but I've also been doing a fairly large general heme practice at UCLH and similarly at North Mid. There's definitely been increasing numbers of referrals to us over the last 8 years that I've been a consultant, and I don't think we've had many of these sessions, so I think this is a great opportunity to refresh everyone about general haematology questions, an opportunity to ask and answer your questions today and give you my view of when you should refer to us. I'm hoping we can have a break sort of halfway through for questions to be fielded and also at the end. And obviously, because of the sort of the I received some questions before this talk from you from previous webinar questions fielded to us. I've tried to cover these, but please do ask these again if I haven't answered your main questions. So just to start the talk, the scope and the contents is really to talk about the commonest reasons, in my view, for haematology referrals and what I see in our clinics and also through advice and guidance. Some general tips to you and advice regarding what we as haematologists would like to see tests-wise or pre-referral tests where relevant. And also to give you a feel about what we consider or what you should consider as urgent, requiring a 2-week wait or even a phone call to us, and what are considered more routine things and when to worry and when maybe to worry less. There's a slide at the end pointing you to some online resources that I've found helpful when preparing this talk. Some I was not even aware of. My wife is a GP and she's helpfully pointed me to those. She works in West London and they've got a nice resource there run from, I think, Imperial. And as I said, opportunities to answer questions as you go along. So I had a quick look back at our North Mid practice recently over the last 12 months from February 2020 to February 2021, looking at what are the main referrals we are seeing in our clinics. This is not advice and guidance, by the way. It's slightly different sort of proportions for that, but quite a high proportion of 2-week wait referrals, nearly 30%. And then a smattering of things, mainly the second highest is sort of abnormalities in low and high full blood counts. Some paraproteins are being referred as 2-week waits, others as routine referrals, mainly those that are causing less worry, so small paraproteins. And then anemia, as you'd expect, polycythemia, and then a range of other things, ferritins, B12s, etc.
Sorry to interrupt you, Saj, but we can't see your slides moving. Have you moved on to other slides?
Can you see my pie chart?
No, we can just see the intro slide at the moment.
Oh, and now?
It's still the intro. It's not in presentation mode. Okay, yeah, we can see the pie chart now.
Can you see it as a full screen?
Not yet.
And now?
I can't yet, no.
I'm sorry about that. Can you see any slides at the moment?
Yeah, we're on the pie chart slide, but we can see it all in like the normal PowerPoint view, not in the presentation view. So we can see your slides going down the side.
It's a bit smaller, that's all. So.
Yeah.
Not too sure what I should do because I'm sharing my screen and I'm going to stop sharing and try sharing again and see if it works.
That's fine. And if you want me to share that, I'm happy to.
Okay.
Might be easier to send it across and then we can share it for you.
Yeah, I think you've got a
I've
copy
already.
of it.
Version, haven't we?
Yeah.
Yeah, that might be. Is that okay for you, Sarge, if we do that?
Yeah, that's fine. I'm sorry about that. I'm
Okay,
not sure what's going on.
I'll share it now. One moment.
Thank you.
Can everyone see that?
Yep, that's great. Should we go? That's lovely. Thank you very much.
So I was talking about this pie chart. So going back to that. So yeah, about a quarter of patients are being referred as 2-week waits. And that proportion, I think, has changed. There's certainly more 2-week waits appearing in the last, compared to, let's say, 2 years ago. I'm not sure whether that's partly related to effects of COVID and how GPs have been working, or generally whether there's truly an increase in people presenting with concerning findings. Abnormalities in platelets, blood counts are the second commonest referral. And then you've got paraproteins, issues around anemia, ferritin, polycythemia, as one would expect. So I'm going to try to cover most of these if I can. I've not actually prepared a significant amount on anemia because I think that's been well covered in other places, and I think GPs have access to quite a lot of resources around anemia, and it's quite a big topic that I don't think I can fit in today. So apologies for that. Next slide, please. Yeah, so it's quite a lot of clicking, I'm afraid. That will make it a bit more difficult. So if you click all of them, so lymphadenopathy is by far and foremost the commonest cause of 2-week wait referrals. And then you've got the checkbox on the North London Cancer for associated symptoms. So that includes weight loss, sweats, night sweats, fatigue, bruising, frequent infections. You're familiar with that. That comes up quite a lot, actually, as a solitary reason to refer. Sometimes there are one or more of these symptoms together. I've noticed quite a few times it's one symptom alone, as weight loss.
Have we lost Sarge's audio? Yeah.
Yeah, I can't hear him.
Hi, Sarge, we lost you for a minute there.
Okay.
We can't hear you.
Yeah.
Not completely. The audio is not very good. I don't know if you turn your, maybe if you turn your video off. So I think I wonder whether especially if Sarge comes off and comes back to the webinar. Would that help?
Yeah, he seems to have frozen.
Yeah, it's completely frozen, I think. Yeah. So I'd give him a ring, maybe, a call. Yeah.
Send a message in the chat. So.
Let's have a look. I think it's probably just better if he just tries to come back on again and see how we go. While we're waiting for that to sort out, what I'm just going to do is take a bit of a straw poll from all of you here today. What have you got particular subjects that you'd like us to cover more than any other subject? Any priority things that are occurring to you? You can speak. That's fine.
Hi, Claire. Can you hear me again?
I can hear. Oh, hi, Sarge. You can. Yeah, I can hear you.
I'm so sorry. I think I'm just in a slightly dodgy Wi-Fi spot. I've hopefully stabilized it now. Shall I carry on?
Please do. Please do. Thank you.
Okay. Can you see my slides at the moment?
We could as you started speaking. Yes, we can. Thanks.
I've just taken it over again.
Okay. So interestingly, at the present time, we've done a look back at what proportion of the referrals we're receiving as 2-week waits are turning out to be malignant, and it's actually less than 10%, probably closer to about 7% in that year period. So a pretty small proportion, if you asked me. And I understand that the emphasis is on looking at symptoms and referring in. However, that does mean there's quite a lot of very anxious patients coming through to our doors being told they may have cancer, and we have to manage that appropriately. Also, I did a little poll of our haematology colleagues about who were vetting some of these or had seen some of these patients, and up to about a quarter of them were thought to have probably been better served through either an urgent referral pathway or an advice and guidance pathway, or they simply should not have come through a 2-week wait pathway. And I think that's certainly higher now than it used to be before. Someone has said 7 to 10% pickup is actually very good. Well, yeah, that's me from a haematology sort of my side perspective, I guess.
I think what that comes from, if I can just interject there a minute, Sarge, if you look at international data and then NICE guidance, if we want to approach the diagnostic and 1-year survival rates that we see in other matched countries to the UK, we need to be looking at conversion rates that probably run around 3 to 5%. That's what the data shows us, which often seems illogical from the perspective that you were just describing, which is managing the capacity aspect of it. So the two things, in a way, don't fit quite together, but that's what the data tells us internationally. So I think that's where that comes from. I also know that we used to have urgent haematology services, like we had urgent for most options, for most issues, cancer or non-cancer, but the systems have progressively done away with those, and so GPs have quite a sort of small number of avenues to get specialist advice, and I think we need to probably revisit that again, as you were saying.
Okay, moving on to the next slide, please. Yeah, I mean, ultimately, this is what we're sort of talking about. I like this slide because there you guys are, guardians of sort of the pathways, trying to scan the horizon for danger signs, and represented here by the tip of an iceberg, and trying to figure out whether there is something significant underlying it or not. And I totally appreciate really difficult task in the short amount of space, short time you have to gauge that. And in haematology, certainly there's quite a lot of different aspects of information coming in. It's not one or two symptoms, but quite a lot of symptoms, quite a lot of data with blood tests. So quite a tricky thing to manage. And then next slide, please. I think there are obviously the clinical factors which are more objective about what makes a doctor look at a result and think this is concerning. So it could be a severity issue around the size of a paraprotein that is worrying, or a clinical examination showing a lymph node that is worrying, or the extent of a full blood count abnormality. Or it could be, instead of expecting just to see one area of abnormality, you can see sort of slightly more generalized, like a lymph node, or instead of one line of blood count abnormality, you've got several lines abnormal. Another sort of factor is about a perception that things are progressing. And again, there is some subjectivity to that, in that the relative progression that may appear significant to some of you may not be particularly concerning to me as a specialist, and getting a common ground there I think is important. And then I think in all of this, I'm going to refer to a group of features which I call the plus features. So that's a blood abnormality or a lymph node or a paraprotein plus something else. And it's when you have those plus features that usually concern is generated. And that's the typical B sort of symptoms people are familiar with. That's drenching night sweats, fevers, weight loss, or associated hepatosplenomegaly. And then I guess there is the factors that we can't ignore, which is the individual doctor's knowledge, the past experience of having come across a similar case or something that smells something similar, and also a perception of how to accept an element of uncertainty or risk. And then you've got the patient factors, the anxieties and the concern. And I don't know how uniform advice and guidance is being available to all of you, and whether you feel you can get quite quick advice. Somebody asked about a phone number to call. We at NorthMed have a hot. I don't think a similar thing exists at UCLH, but you can get hold of a registrar or someone for advice quite quickly in most places, in my experience. Next slide, please. So I'm going to dive into the sort of meat of the matter, and I think common things are causing problems or concerns and interpretation. I think of all the problems that we see in general hematology, paraproteins are probably the thing that generates the most amount of work. And I think both sides, from a GP perspective, a bit of uncertainty as to what to do with it. And also we tend to see them diagnosed, the majority, as one would expect, with MGUS, and then end up asking you guys to keep an eye on the patient's paraprotein. And I think it's an evolving field. We're going to have hopefully clearer pathways of what to do with people with paraproteins and MGUS. But this is just a bit of background about paraprotein, how to interpret paraproteins, and how to refer. So I've got a few slides on that. A paraprotein is, as you know, a monoclonal immunoglobulin, which shouldn't normally be present in a healthy immune system situation, where you should have a general representation of all the different subtypes of immunoglobulins, but not a band or a peak in one specific subtype. It's detected on a test called a serum protein electrophoresis, and the majority of these paraproteins are either IgG, IgA, or IgM. Their associations are numerous, and according to the size of the writing is the association to the frequency. By far and foremost, monoclonal gammopathy of uncertain significance is the commonest, followed by myeloma and lymphoproliferative disorders and amyloidosis. I guess from a point of view of picking serious problems, delineating whether a paraprotein is related to myeloma or to a benign condition, an MGUS, which is highly prevalent in the general population. Up to 10% of people over the age of 80 will have it. So with an aging population, we're bound to be picking this up more frequently. And about 3 to 5% of people over the age of about 65 will have it. So if you look for it in general population, you'll find it. And because the association between the paraprotein and these CRAB criteria, the myeloma sort of typical features of high calcium, renal dysfunction or renal impairment, with or without some proteinuria, anemia and bone symptoms, mainly bone pain, particularly back pain or abnormalities on an imaging, which are not uncommon in people with type 2 diabetes, hypertension, people with other issues such as primary hyperparathyroidism. So these are a mixed bag of things that you're then asked to kind of correlate with whether the paraprotein is connected with or not. So quite a challenging thing to do in my view. And then some other symptoms which are again non-specific: fatigue, some symptoms of shortness of breath, ankle swelling, neuropathy, which can be associated with paraprotein disorders, including amyloidosis. So the common test that will be requested as a screen for people with these one or more of these abnormalities, of these CRAB criteria, or where there's concern about suspected myeloma, will be a serum protein electrophoresis. And sometimes what you'll get is a polyclonal increase in gamma globulins. And polyclonal increase in gamma globulins are effectively a situation where all your immunoglobulins or a proportion of your IgG and other immunoglobulins are all increased proportionally, and is not then concerning for myeloma. But it can be associated with occult infections, such as viral infections. HIV can give you that typical gap in your total protein and your albumin, which is where the gamma globulins are, what is made up by gamma globulins, lupus, other autoimmune diseases, and sometimes other solid malignancies. And if you do pick up polyclonal increasing gamma globulins, generally the target of attention should be those kind of conditions, and not a referral to haematology, because we are not going to really be terribly helpful in those situations. Within a polyclonal increase in gamma globulins, sometimes, and I've seen that quite a few times in people presenting de novo with lupus and other conditions, autoimmune conditions, you can sometimes pick up a faint paraprotein. And that's just an immunological phenomenon whereby one particular antibody is slightly overrepresented over the others. Generally, it's transient. Generally, it's very faint. It's reported as often too faint to quantify the paraprotein, and usually it goes away if you check it again. Next slide, please. Sorry, next slide, please. Yeah, thanks. So this is what the myeloma screen is about. So in the first picture on the left, you've got a situation of normality at the top with normal plasma cells, and at the bottom, you've got a clone of plasma cells producing too much of one type of immunoglobulin, as opposed to the multicolored polyclonal situation. And the serum protein electrophoresis will pick that up. Will pick that band of abnormal overproduced monoclonal immunoglobulin up as a band within the gamma globulin region. It will then undergo a test called immunofixation automatically, which is a way of identifying the subtype and also quantifying the immunoglobulin size. So you'll be then given a result in terms of whether it's an IgG, an IgA, an IgM, and with the appropriate light chain that comes with it, and the size of the paraprotein. That's one aspect of the myeloma screen. The second essential aspect of the myeloma screen is the detection of monoclonal light chain. So plasma cells produce intact immunoglobulins, but they always almost also produce light chains that are secreted in the serum that are circulating. And that applies to both normal plasma cells, but also the malignant plasma cells. And traditionally, urinary Benz-Jones protein has been used to detect renal excretion or renal lack of renal reabsorption of these excess light chains. However, nowadays the move has largely been to test using a serum assay called the serum free light chain assay. And I think the uptake of that is variable. Some practices are not able to request this on their path ordering system, and others are still are able to. So I've seen a smattering of referrals containing light chains and others requesting urinary benzoate protein. The current BCSH, or British Society of Haematology, guidelines for people being assessed for paraproteins has now recommended that serum-free light chains should be used, and I think that's an area we need to look into, because there's a bit of education to be done around how to interpret these tests. So the next slide talks about light chains. If we move on to that, please. It's a bit of a lag in the, yeah. So serum-free light chain assay effectively picks up these little the epitopes on the free circulating light chains, as opposed to that's bound to the immunoglobulin molecule. So that epitope is visible in the free light chains, but not in the bound state. And it is certainly definitely more sensitive than urinary benzoate protein. Interestingly also, and that's why it's important to do the light chains assessment, is that about 10 to 15% of people with myeloma will have no paraprotein detected. And that is because the abnormal plasma cell clone does not produce intact immunoglobulin. It produces only light chains. So that's an important consideration, in that your myeloma screen is not complete until you've checked for the light chains as well. And you'll pick up more cases than if you did just the urinary benzoate protein. The normal reported range for the kappa and the lambda light chains, which are the two main light chain subtypes, is between 0.3 to 1.65. One word of caution really is in the context of renal impairment, where the excretion of kappa is impaired relative to lambda, and therefore it skews the ratio in favor of kappa, so giving you a slightly different range in the context of renal impairment. And I guess the degree of renal impairment will affect that range to some extent. So that makes interpretation of line chains a little bit more difficult. Really, the situation when one worries about myeloma really is where you start getting kappa to lambda ratios of well less than 0.1 or well over 10. And that's where you really should be considering referring those patients urgently. The other situation is the absolute amount of a certain light chain is quite high, such as more than 100 milligram per liter. Next slide, please. So MGUS is the commonest reason someone will have a paraprotein. As I said, it's quite common. It's a benign condition. However, what we do know is that everyone who develops myeloma will have had an MGUS state for a variable amount of time, some for shorter periods of time and some for longer. So it seems that having MGUS involves the presence of a clone that is not malignant at that point, but there are further transformation events that then the patient develops over time that then turns them into a myelomatous state. How do we then know who, at the time of presentation with a paraprotein, has an MGUS which has a higher risk of developing into myeloma than others? Otherwise, we'd end up lumping everyone into one basket and giving them a kind of broad risk of about 1% per year, which is what the textbooks generally mention. The Mayo Clinic in the States, for some years ago now, have done some very interesting work on that. And this sort of graph here tells you what the three main factors that were found to be useful as a scoring system to predict who is more likely to develop myeloma. The three factors are the size of the paraprotein, and the second one is whether you've got a non-IgG MGUS, such as an IgA MGUS, which carries a higher risk than an IgG MGUS. So a paraprotein size of more than 15 grams per liter, an IgA MGUS, or an abnormal serum-free light chain ratio. If you put that into a simple score risk of 0 to 1 to 3, you get very different progression rates to myeloma. For instance, the group with the lowest risk, low or low intermediate score of 0 or 1, will have a risk only about 5% or less at 20 years of developing myeloma. Now, if you're picking up MGUS in someone who's 80 and their predicted lifespan is another 5 to 10 years, then that risk is almost negligible, to be honest. But if you're younger, obviously that cumulative risk over time is significantly higher. And if you have got those parameters that put you in a high-risk group, then your likelihood of MGUS transferring to myeloma is higher. So what we are doing in practice is we're selecting out the higher risk patients, and we're keeping them in our clinics for monitoring, which we do through either telephone clinic or remote clinic, or sometimes face-to-face where relevant. And we monitor them for symptoms, and we monitor their paraproteins. For the lower risk patients, generally once every 6 months to once every year blood test, which is simply looking at their paraprotein level and the CRAB criteria that I mentioned before. So that's your calcium, your renal function, your hemoglobin, is sufficient, as well as a short review of symptoms of whether they have got any concerning symptoms. Education of patients at baseline is what we also try to do, so that they have access to information. Myeloma UK has a very helpful leaflet on paraproteins and MGUS, which I tend to give to all the patients I'm diagnosing with MGUS and giving them sort of warning of what to generate an urgent clinical review in the future. Next slide, please. So I formulated some referral guidelines. I don't want to go through these in huge detail, but I think I've lumped them into 3 main groups. Those patients who I do think you need to call us urgently. Those are people with the significant CRAB criteria. So that's a calcium of more than 3, significant change in their renal function compared to their previous blood test, a significant anemia that has evolved, such as a 2-gram drop without any explanation, and or if they've got concerning features such as neurological symptoms suggestive of potential cord equine or cord compression, or if you're concerned about something about them, very happy to have a phone chat about these patients, and they may need to come to A&E to be assessed urgently. The 2-week wait referral groups, those are patients who have significant CRAB features, but not of the severity that would fulfill a phone call, such as a calcium less than 3, a significant change in renal function, but not overly concerning. They can wait 2 weeks, in your view, to be seen, or a significant abnormal serum free light chain ratio, as I've mentioned before. So if they've got these plus symptoms as well, so abnormal lymph nodes or significant weight loss, or amyloid type symptoms, which is a rare condition, but I think worth remembering. Someone coming in with a paraprotein, with an unexplained congestive heart failure, proteinuria, neuropathy. Amyloidosis is a rare but very serious condition that should be seen urgently. Second group for 2-week wait referral would be those with a paraprotein of more than 10. I think that's sensible, and those with the ratios of the kappa to lambda being outside the ranges that I mentioned, so more than 10 or less than 0.1, or the light chain size of more than 100, which makes myeloma more likely, although not definitely a myeloma. And then all the other patients, I think we probably can do an advice and guidance or a routine referral if there are no concerning features. So that's my take on it. I agree there's no national agreed pathway for these patients, and I must emphasize this is my way of risk stratifying and giving you advice on what to do. It might differ in the future. There might be other pathways that are out there that the numbers may differ, and I've certainly seen some online resources that have slightly different numbers to what I've put here. Next slide, please. Thank you. So those are the 4 slides I had on paraproteins. I'm sure that would generate some questions. One question that was asked was, when should we refer patients with abnormal lymph nodes? And that's why I've included this slide. I think this gives you some indication. The difficulty with lymphadenopathy, I think, is that it's really something that I have developed over time with experience. And I think the more lymph nodes you feel, the more confident you become with them. And I'm not sure that in your day-to-day practice you feel enough lymph glands, some may not, to really have that experience. And I think that's where some focus for sort of education, it's a bit difficult, I think, but I don't know what GPs have at hand to get more confident with assessing lumps in the neck, lymphadenopathy, etc. As a broad sort of size criteria, in the neck, lymph nodes over 2 centimeters are abnormal. In the groin, you're allowed 2 centimeters, and they're much more easy to feel than in the neck or axilla. But as a broad rule, 2 centimeters and above is abnormal and probably should generate a referral. Feeling the consistency and all that, I find really difficult, to be honest, and I find it hard sometimes myself when I feel a lymph gland to know, is this firm or is it rubbery, is this soft or not? I find this a difficult one, but some glands you'll clearly feel them as fixed, hard, and those are kind of the clear-cut ones, but there's a grey area in between, I agree, when you're feeling with your fingers. And in those cases, if the patient has got other associated concerning symptoms like the plus symptoms I've mentioned before, or they've got significant blood count abnormalities or raised inflammatory markers, I think those should generate referrals. And obviously the differential is broad. They could have a malignancy, clearly, metastatic cancer, lymphoma, or a nasty infection such as TB, or sometimes HIV. And I think it's important to consider doing those kind of tests if you have time and if you're not particularly worried. If you've got someone with a whopping mass, clearly you need to refer them straight away or call us. And where there is a bit of time to investigate further, consider breast exam, a chest x-ray, an HIV test, and examine their throat, because metastatic oropharyngeal cancer is not uncommon in smokers particularly. And then you're left with a group of patients where you're not entirely sure, and I think it would be reasonable to consider an ultrasound if you have access to that and you're not worried before you refer to us, but that should not delay a referral where you're concerned, in my view. That's what I had to say about lymphadenopathy. Happy to take questions later on that. Next slide, please. Sweat. I feel that's the most common cause for a bit of a moan when we receive a referral just purely for sweats, because I think sweats are really very common, and I've yet to come across a patient referred to me, and I'm being honest here, with isolated sweats where we found, oh wow, they've got lymphoma. I'm yet to see a patient with isolated sweats where lymphoma is the cause. And I think it's up there in the 2-week wait referral sort of tick box. And I think quite a few patients get referred through that route. And some people are really worried, having read about drenching night sweats, and are concerned. However, if you've got no blood count abnormalities, you don't have any plus features, you've been examined and you don't have lymphadenopathy, a liver or a spleen, I think you're very unlikely to have lymphoma, particularly if you've had these symptoms for more than a few months. Now, acute symptoms with sweats could well be infections, and I think most of these patients, if they don't have any overt other concern, probably should be monitored for a period of time before attributing as this sort of persistent drenching night sweats that need immediate referral. Obviously, there's a long list of causes for sweats that you're more familiar with than me. Endocrine causes, autonomic neuropathy, people who have alcohol excess, anxiety and stress, sleep disorders, SSRIs. The list is quite long. And teasing out what the sweats are due to is sometimes tricky, and obviously we always worry about the most concerning one, and lymphoma seems to be at the top of people's minds and patients' minds. So I think people who should be referred as 2-week wait are those who do have drenching night sweats, and I think teasing out this element, drenching night sweats, is really important, because if you ask people off the street, do you have sweats, the rate of positive reports is probably quite high. Some will have sweats once a week, others will have them once a month, but clarifying the frequency and the severity is important. And if they do have these plus features, do refer them 2-week wait, not a problem. Next slide, please. Yeah, it's 1:10. I'm just going to have a short break for questions about those topics I've discussed. I can't hear you, Claire.
Thanks very much. Thank you. If we go first to just quickly the testing options, MGUS and BJP. So we've got lots of questions in the chat about what tests are available to people. It is slightly variant across the geography, unfortunately, at the moment, because of the 5 separate pathology systems that exist, one in each borough. Now, as I think, and you may know more about this, Saja, that the HSL lab, if they receive a request for BJP and they've got access to a variation of samples, they'll actually put through an MGUS test instead. That's what I've recently been told. I don't know what
the serum free light chain test.
Yes.
So I think Jonathan Siv, who's written the recent BCHS guidance, has been working with the HSL, which covers quite a few of our main NCL hospitals, certainly. I'm not entirely sure whether that's definitely happening. I can't say for sure. But that sounds like a good idea. My main comment on that is GPs spend a lot of time, I think, trying to get patients to do urine tests, and it doesn't work. Whereas this allows you to do a one-stop shop test. Agree there's a few interpretation difficulties, but I think it makes your life easier at the end of the day. So I think there should be a push to try to get that test available to you.
Okay, and there's a question around which electrophoresis tests to request in terms of the labelling of it as well. Okay.
So I guess the commonest mistake to make is to request a hemoglobin electrophoresis, and that's completely different. I know it as serum protein electrophoresis or serum electrophoresis. That's the only test I know that's relevant to this problem.
Okay, thank you. If we, I'm just scanning through, I think we haven't got any other questions in the chat about that. If we move to lymphadenopathy, one of the things which you emphasised when you were speaking was the necessity for a physical examination. So I'm just raising that particularly because, of course, certainly more than 50% of our consults at the moment are not face-to-face. And so that's just, I guess, as a reminder.
I agree. That's really challenging, actually, because patients are coming with sebaceous cysts to us as 2-week waits. Patients are coming with completely unrelated lumps, which, you realized had they been seen, formerly lipomas, it would have been picked up. So I guess it's a question of what is right here, and what, I don't think everyone can necessarily at the present time be seen face to face, and I think that's something that primary care has to decide. I mean, when patients are calling with lumps, do they need to be prioritized? As COVID is being, vaccinations happening, COVID is going down, do these people need to be seen face to face? And I do think for us, certainly, if you refer someone with a lump, I can't have a telephone conversation with them, and I have to see them.
Absolutely, yeah. I think absolutely. It would be helpful if people probably tried to see patients face to face if they were considering a 2-week wait referral. I don't know what anyone else feels. I could pick people out just to sort of talk about to share their own experiences around this dialogue. Maybe either Tal or Nitu have both talked about, have been active in the chat today. I don't know what either of you two feel about whether it's what we said around being fair to see someone face to face before doing a 2-week wait. I know what I think personally, but I'd be interested to hear what you say. Yeah, so Tal said he agrees.
Claire, I completely agree. Otherwise, we're really shooting in the dark. So Sandy, I agree with Sajid's comment.
Yeah, thank you. Thanks. So I think it is difficult, and I think Tessa's come in and said something similar. So what all I would say is really try to arrange that. There are obviously mechanisms in your practice to arrange face-to-face appointments, and be aware that the percentage of our patients that are seen in extended hours or extended assessment slots provided by local federations or local hubs is increasing, and therefore those hubs may be asking people to come back to practice to be examined at least some of the time. So we just have to balance that and just be aware that might happen. Yeah, we just got more people talking about that.
I've got quite a few more slides, so if you want me to carry on, I think I probably should.
That's fine, thank you.
Okay, moving on to blood abnormalities, and there's quite a few slides about this. I think I'm probably going to cover the commonest ones because I won't have time to do all of them. But I think the key message around blood abnormalities is one, obviously consider severity, have an idea of what constitutes severe, medium, moderate severity for each of the main lineages. Absolutely essential to consider the clinical context, and you all do this, I know. Medication sometimes gets forgotten about, particularly when it comes to things like neutropenia and thrombocytopenia, but timing of when they were started is important. And again, is it in isolation or is it happening in the context of some concerning plus type features? This is my terminology, by the way. It's not. I call them the plus features, but you can call them what you want. Are they isolated? So have you got an abnormality in one lineage, such as the neutrophil, and a platelet abnormality? That's slightly more concerning. Or is it an isolated abnormality? Or is it a pancytopenia? Looking at previous results, I find this incredibly helpful. One of the nice things about UCLH and EPIC is now we have the HIE system, which I can then access your previous blood results in clinic, which is really helpful. NorthMed, unfortunately, I don't have that luxury, and I think other hospitals probably don't have that luxury. But where possible, please attach previous results, particularly when things are like neutropenia or mild thrombocytopenias, etc. Really helpful to know what's happening in the past. Most results, except when you're very concerned or the results are very high or very low, can be repeated in 4 to 6 weeks before you consider an advice and guidance or referral. I think that's eminently sensible, and unless you think the patient will come to harm due to their symptoms or the level of their count, and I've put some broad ballpark kind of figures when you might consider doing that. Lymphocytes of less than 10, I wouldn't be worried if the patient's well. Neutrophils up to 20, hemoglobin above 100, platelets more than 50. I don't think patients would come to harm if they waited 6 weeks to have these rechecked. And then you can consider advice and guidance for those with mild changes and then decide whether to refer. Carrying on. So what platelet count worries me is a platelet of 50 or less. Unless the patient is on antiplatelets and anticoagulants, or unless they have an unusual pattern of bleeding, which a simple history and questions will tell you. In all people with thrombocytopenia, the differential is very, very broad, and I think I don't want to go through a long list of causes here, but I think some basic assessments that you could do, apart from asking about concerning symptoms that I've mentioned before, is looking at the rest of the full blood count, doing a blood film. Pseudo thrombocytopenia or platelet clumping is not so uncommon. It's a purely in vitro phenomenon. It has no bearing on the patient. And you can send off a blue top or a clotting sample, a citrate sample, which can sometimes correct the abnormality. It's purely to do with an antibody in the patient's serum that activates in this medium in which their full blood count is collected, which is EDTA. People with liver disease, even fatty liver, and obviously other more serious concerns with liver are often associated with blood count abnormalities, and particularly platelets. And it's very common to have platelets below 150 and between 100 and 50, and sometimes below that if you've got cirrhosis and splenomegaly, etc. It is imperative that all patients get a viral screen if possible, and HIV can present with an isolated thrombocytopenia or a neutropenia for that matter. Similarly, chronic unknown hepatitis B and C, I've picked up a few of these patients before presenting to us with isolated thrombocytopenia. A coagulation screen and fibrinogen, probably not essential, but helpful if you've got someone with bleeding symptoms, and may help make sure they don't have something serious like DIC. And then autoimmune thrombocytopenia is quite common. So that's thrombocytopenia associated with an underlying autoimmune condition like lupus. And you can do an ANA, rheumatoid factor, and ESR, particularly if they've got rash, vasculitic symptoms or joint symptoms. And there, clearly, those patients will be served better by being referred to the right specialty rather than to haematology, because the thrombocytopenia is secondary to something else. There's some referral guidance here, which is really, if you've got someone with platelets of less than 20 and or bleeding symptoms, you should call us. That's a seriously low platelet count. Ideally, they should have a repeat within the 24 hours, just to make sure this is not a sampling problem, because it can happen, particularly if it's incongruous and it doesn't fit with the patient's symptoms. Low platelets, I would say any low platelets with concerning symptoms, consider a 2-week wait. If you've got persistent platelets between 20 and 50, an urgent referral is advocated, to be honest, and where you've repeated it. And then patients with platelets 50 to 100, they're unlikely to come to harm unless they're on anticoagulants and things like that, or they're having significant bleeding problems. Advice and guidance and routine referral for those. And then most people with platelets between 100 and 50 probably don't need to come to us, and an alternative cause may be found, or if it's persistent and can be repeated. These are not set in stone, of course, always open to be sent advice and guidance requests for these. Moving on to the next topic, please, neutropenia. Quite similar in approach to thrombocytopenia. Important to delineate kind of severity, and most people will say less than 1 is considered associated with an increased risk of serious infections. To be honest, it's really less than 0.5, but I think for the purposes of this talk, 1 is fine. That should always generate a repeat count within a week, unless you're worried that the patient has leukemia because their blood count has highlighted something else, or a blood film has highlighted something else, in which case they may need to be referred more urgently, a phone call or a 2-week wait referral, I think, depending on their symptoms or how serious their presentation is. Obviously, if someone is unwell, they have fevers with a neutrophil count of less than 1, you'll need to refer them to the hospital. It would be very difficult to know whether they've got an infection causing neutropenia unless they've got good-going EBV type symptoms, tonsillar symptoms, and they're young and otherwise not unwell, but just a fever with viral symptoms. I think those patients are often neutropenic transiently. So I think gauging the patient and how unwell they seem to be and whether they have a simple viral illness or not, I'm not saying it's straightforward, but I think that's how I'd be thinking. Most patients with a neutrophil count plus features and a blood film that's abnormal and suggestive of either myelodysplasia or leukemia will need an urgent referral. And then the list of causes is for people without a bone marrow problem is broad, fairly similar and overlapping with the causes for low platelets, except for one thing being the ethnic neutropenia, which is not uncommon in our patch in London, in North London, where we have a significant Afro-Caribbean community. And I think this is something that I would hope that eventually we don't get referred patients where there's a high likelihood of this, because it is ultimately a diagnosis of exclusion. There's no test that I can do to prove this patient has benign ethnic neutropenia. The only tests are going through the above causes and making sure they've had at least a full blood count repeated, they've had a blood film looked at, they've had an HIV test, potentially a hepatitis B and C test, and looking for any chronicity that you can find from previous results. But if they have the right ethnicity, they've got the historical results, they don't have features of autoimmune disease, there's no clear viral cause, I think by exclusion these patients have benign ethnic neutropenia. Where needed, we can provide advice and guidance. Next one, please. First thing to say about neutrophilia is it's really very rarely something of concern to us in haematology. The incidence of people with a chronic myeloid leukemia, which is an extremely rare leukemia, or a variant of that called chronic myelomonocytic leukemia. It's pretty rare that these patients will present with sort of mild neutrophilia that's persistent over a few months. Usually it rises quickly, if it is that. And usually these people have neutrophils well over 20 to 30. Or a blood film that has highlighted clear problems suggestive of a bone marrow etiology. In the vast majority, I would say 95% or more of patients, you're dealing with benign, transient, or persistent underlying causes such as a chronic skin condition, bowel conditions like chronic inflammatory bowel disease, and if it's acute, then an infection, usually a bacterial infection. Smoking is a common cause, and also of lymphocytosis. And if someone is a chronic smoker and they have persistent mild, moderate neutrophilia, I think it's reasonable to assume it's connected. Where you're concerned if they've got a cough or symptoms, red flag symptoms, reasonable to consider chest X-ray and GI workup, etc. Moving on. Polycythemia. I think an initial assessment of polycythemia in primary care is really important for secondary or relative causes, because by far that is the commonest etiology. Smoking, chronic lung diseases, people with sleep apnea, patients taking certain drugs such as testosterone replacement, alcohol excess, patients with heavy-duty diuretics, etc., all have a higher chance of having a relative or secondary polycythemia. Now, the most important message is that those patients do not have an increased risk of thrombosis, not unless the hematocrit is really hitting like 0.60 or above, and a hemoglobin of over 200. And only in those cases really does the evidence suggest you might have to intervene with some venesections. The key question is, if you can't find a cause in your history and in your assessment, could they have a primary polycythemia? And we're more than happy to see these patients where there is this question, because we now have a simple test to rule a primary cause out. Where a primary cause will be more likely, obviously where you haven't found a secondary cause, or where there are coexisting abnormalities in other blood lineages, such as the neutrophils, eosinophils, and platelets. Patients with splenomegaly, patients reporting sort of pruritus on hot showers and the typical sort of sweat type symptoms that people with primary polycythemia are reported to have, or where they have any kind of concerning neurological symptoms. They've had a thromboembolic event recently, or have odd visual and neurological symptoms, headaches. By all means, refer those patients. And the severity of the hemoglobin or the symptoms probably will dictate whether it's a 2-week wait or not. But by and large, most patients are referred as either urgents or routines. Next slide. Thrombocytosis in primary care, not uncommon. By far and large, the majority will have iron deficiency if they're a woman of having periods. That's the first thing that one should check and replace iron. Iron deficiency is the number one cause of high platelets in women of childbearing age with or without menorrhagia. And dietary issues in older patients, and obviously in older patients, consideration of whether the iron deficiency, if they do have iron deficiency, is related to an underlying other more serious cause requiring a 2-week wait to gastro, etc., need to be considered. Thrombocytosis is common in people with chronic inflammatory diseases and can be seen as an acute phase response. We've seen lots of people post-COVID develop significant thrombocytosis, which then settles over time. I think where you need to really discuss with us urgently is where the platelets are over 1,000 without any clear cause. If they've got significant risk factors for thrombosis or have had thromboembolic events or neurological symptoms, those patients may need to be seen urgently, more urgently than a 2-week wait referral. Most patients with platelets over 450 with associated other high counts, such as a neutrophil over 20, high eosinophil or polycythemia, will potentially have an underlying significant myeloproliferative disorder, and it's justified to do a 2-week wait. Most patients with platelets between 450 and 600 without any significant reactive cause, and where there is evidence of persistence, can probably be referred routinely. Patients more than 600 consider an urgent referral if no reactive cause is found. I think the commonest reason of lymphocytosis I've found persistently is smoking, and that applies to some extent to neutrophilia as well. And those patients have a modest lymphocytosis, usually around between 4 to 6 or so. And really, people with that kind of level of lymphocytosis of less than 10, as a hematologist, we really very rarely worry about if they've got no associated symptoms. So no plus symptoms, no other blood count abnormalities, and if possible, if they've been examined, no lymphadenopathy or hepatosplenomegaly. If they have got any such features, then any lymphocytosis more than 5 with any plus features, or if the lymphocytosis is more than 20, I think you need to refer to us on a 2-week wait basis. The rest, for lymphocytes, maybe between 10 and 20 or between 5 to 10, I think a routine or perhaps urgent referral is reasonable, provided they've been repeated at least once to check for whether they've resolved, maybe 6 to 8 weeks after being found. I often get questions about atypical lymphocytes on a blood film. Now, atypical lymphocytes, the word atypia causes worry, but actually it's not referring to a malignant kind of clonal lymphocytosis. It's just a word which is probably erroneous, and we should probably stop using that. It relates to just lymphocytes that look like they're reactive, they're activated. You see them a lot in people with EBV, but they're not malignant. And I think you shouldn't worry if you see atypical lymphocytes. Next one. Lymphopenia. Yes, I'm not particularly worried about low lymphocytes. I don't think you should particularly be worried about low lymphocytes. Lymphocytes do decline with age, and it's very common to have patients with lymphocytes between 0.5 and 1 in completely healthy, otherwise well elderly patients over the age of about 70. Lymphopenia is seen in acute settings, such as a recent infection, patients who've got who've undergone some sort of recent health problem, a surgical procedure, etc. People who are on corticosteroids often have low lymphocytes, so they can either be on immunosuppressants, immunomodulatory drugs if they've got autoimmune diseases, and generally that should not generate a referral. The person who's initiated the immunomodulatory drug like azathioprine or MMF should really have some cutoffs to advise what to do and whether to stop or not. Sometimes they ask us, I'm not entirely sure that's appropriate because we don't tend to prescribe these medications and we don't know what the indication or the reason to stop or the risk of stopping would be. But if you do see someone with low lymphocytes of less than 0.5 without a cause, you may wish to ask us. The commonest things to do are checking HIV tests and autoimmune screen. My slides have disappeared. You still got them up?
No, not now. They've just gone now.
Maybe, yeah, I don't know how many participants are still listening in.
We've got quite a few still. Yep, absolutely. Okay.
I think my last slides are about B12 and ferritin. I think.
Should we leave those for another time, Saj, do you think?
Yeah, absolutely. So at the bottom of my presentation, you'll see some resources which you may want to have a look at. I was quite interested to hear there is something called See the Signs. Have you heard of that?
Yes,
it's a digital tool apparently.
So it's not a tool that we have in NCL. We've made a commissioning decision about that, not to have it. But the data, the techniques that it uses are we already have in some of our other platforms. But as so I don't think we won't be commissioning that.
Okay,
at the moment.
Fine.
Yeah. Okay. That's really helpful. I can see there are lots of questions, and I'm sure people would probably like to have the opportunity for you to come back again. So maybe we could talk about that and try and arrange sort of another haematology follow-up, which brings all that together and gives the opportunity to cover the B12 and ferritin as well.
Yeah, no, absolutely fine. And we could do it a purely question and answer session, which is probably better suited to what you guys wish to do. And I'm more than happy to book something similar.
Okay, thanks. I'll speak to you outside the meeting and we can put that together. Thank you very much.